At DDW 2024. This session is sponsored by the SSAT, the AGA, and ASG. The topic for this symposium is endoscopic and operative approaches to obstructions and fluid collections in pancreatic disease, principally pancreatic head disease, palliative measures, and rescues. So pancreatic diseases, as we all know, are particularly pancreatic ductal adenocarcinoma, are on the rise and have a dismal patient outcome. A large component of helping people with pancreatic disease is managing symptoms and complications of their disease, as well as the complications of the treatments we provide. These palliative measures require a multidisciplinary approach, and for these reasons, DDW has prioritized this symposium for this year's meeting. I'm John McAuliffe. I'm an associate professor of surgery and pathology at Montefiore Einstein, and my co-moderator, Monica Dua.
I'm a hepatobiliary and pancreas surgeon at Stanford University. Good afternoon.
As you can see in your program, we'll hear from 4 experts in the field. After their talks, we'll have what we hope is an interactive dialogue between the audience and our presenters as kind of a panel discussion regarding the managing some difficult cases. And I invite folks that have difficult cases in their history to come up and talk about those. I'd like to hold questions until the end so we can have a lively discussion at the end. So our first talk is the scope of the problem, the overview of obstructions and fluid collections in benign and malignant pancreatic disease by Dr. Eugene Seppa. He is Associate Professor of Surgery at Indiana University Hospitals in Indianapolis. Thanks for joining us.
All right, thank you very much. Get the slides loaded here. All right, well, welcome. I was given the task of starting us off with a very generic overview. I think that our additional presenters will give much more specifics of their approaches to management of these conditions. I'd like to start with this little cartoon. This is kind of the way I feel whenever I'm called on consults. Not in clinic. Clinic, I usually have much more rosy disposition, but when I'm going to consult about a patient with a pancreatic problem, this is kind of the way I feel. At any rate, I have no disclosures. And so let's start with the problem. I find the pancreas as an organ is really as fickle as a cat. And so this little cartoon kind of depicts sort of the way I feel about the pancreas. You don't know that it's there when things are good, but you definitely know that it's there when things are not going well. And so this sort of depicts pancreatic disease in a nutshell. Now, to give a brief outline, we'll review briefly in my presentation benign conditions of the pancreas, pancreatic neoplasms, and then I break it up into sort of 2 components. I'll overview of the anatomical sites of GI obstruction, which is really kind of the main focus of this session, and broken down by pancreatobiliary obstructions of the pancreatic duct or common bile duct, but also as well as the alimentary tract, the stomach, small bowel, and colon. And then we'll end with a brief overview of fluid collection, acute peripancreatic fluid collections, walled-off pancreatic necrosis, and pseudocysts. So for benign pancreatic conditions, acute pancreatitis is the one that probably we all know the best and usually provides the most difficulty in patient management. Chronic pancreatitis, more elective management of pancreatic conditions, but also can be very severe. Probably an under-discussed would be traumatic pancreatic injuries, which some of us see routinely, some of us don't, depending on the practice patterns that we have in our hospitals. And then certainly congenital abnormalities like pancreatic divisum and annular pancreas fall into this category. Now, let's begin. I know this is a busy slide, but really the point here is acute pancreatitis. We're mostly speaking about severe acute pancreatitis, which is approximately about a third of patients who have troubles. These patients are certainly symptomatic, and they're managed sort of maximally medically speaking. A third of those patients could go on to develop pancreatic necrosis. They have their own unique symptoms, typically as inpatients. And there are various therapies, including maximal medical therapy, interventional radiology, certainly GI and surgery have important roles in that as well, which has greatly changed in the last 10 years, as we all know. Some of these patients will have sort of acute peripancreatic fluid collections. They have their own unique set of symptoms and therapies. But certainly it continues with pancreatic duct strictures, walled-off pancreatic necrosis, as well as disconnected ducts and pseudocysts. All of these have very unique presentations, timing and presentation, and then really a multidisciplinary approach is required to know which therapy is best timed for which problem. And I think we've all been through this. Chronic pancreatitis, certainly in our center we see a lot of this. Tobacco, the primary sort of culprit. Certainly alcohol and hereditary forms of chronic pancreatitis are present. These patients develop pancreatic fibrosis. Their symptoms are exocrine and endocrine dysfunction. There are therapies for that, both elective and sometimes more urgent. The formation of pancreatic duct stones and strictures also have their unique forms of symptoms and subsequent therapies. But certainly this is a unique component that's really specific to both the GI and surgical specialties. Also, chronic pancreatitis is known to cause common bile duct strictures, as well as duodenal strictures, again, with very unique presenting symptoms and therapies subsequent. Pancreatic trauma, so direct injury, either blunt or penetrating injuries, and we have this nice classification here on the right. Typically, these are diagnosed either incidentally in CT and emergency departments and PAN scans, and then sometimes during exploration for trauma laparotomies for other indications. In terms of kind of therapy, typically less is better. The principles are control the hemorrhage, identify the lacerations, typically omental patches, wide drainage for the presumed pancreatic fistula that they're going to get, consideration for feeding tube, G versus J versus GJ, and then really limited use of pancreatectomy. I think most pancreatic surgeons have done traumatic pancreatic resections for various reasons. Everyone has a story where it's gone well, but everyone has a story where it's not gone well. And so we really try to limit it. The expectations for these patients are you should assume they're going to get a pancreatic fistula short term, and then look actively for pancreatic duct strictures in the long term. Pancreatic divisum. I talk more about pancreatic divisum than I treat. I'm sure that's most of us, to put it mildly. So the prevalence is very high. 10% of the human population is expected to have pancreatic divisum. We assume somewhere about 2% of that 10% actually have symptoms. They behave like chronic pancreatitis, but not with a lot of the manifestations of chronic pancreatitis, both from an endocrine and exocrine dysfunction, but also on imaging. Some of these patients would proceed to endoscopic minor papilla sphincterotomies, but again, I try to drag my feet on these patients because probably there's some other underlying problem as the source of their symptoms on average. Annular pancreas, in our center, Nick Zaromsky has sort of been the champion of this. The prevalence is particularly low, at 0.1% of the human population is expected to have annular pancreas. Now, symptomatically, they're very high, if not discovered as sort of a duodenal atresia in infancy. If they reach adult ages, we expect probably a third of these patients will present with what appears like a gastric outlet obstruction. And typically the therapy is some version of duodenal decompression, most preferring a duodenal duodenostomy. Now let's transition from benign pancreatic conditions to, let's start with pre-malignant pancreatic neoplasms. In our center, we deal a lot with these. Thanks a lot of the work to one of my senior partners, Max Schmidt. We follow quite a few kind of pre-malignant lesions, serocystic neoplasms, probably less than 30 reported cases in the literature of actual malignancy, but certainly mucinous neoplasms, IPMN, MCN, with lower risk, lower rate of harboring invasive malignancies when you look at all comers. Pancreatic neuroendocrine tumors maybe as high as a 10% risk for malignancy, and then pseudopapillary neoplasms maybe a 2% expected lifetime risk for malignancy. Now, most of these patients, we end up operating on them for symptoms, not necessarily malignant risk. A lot of us like the, one stone for two birds sort of analogy, but if it's low-hanging fruit when one of these patients has pancreas-specific symptoms in terms of their management. Now, reasons we might take care of these with some form of therapy would be if they have high-risk malignant features, in essence, we consider symptoms a high-risk feature, although we know for certain these cystic lesions or precancerous lesions that, their symptoms might be related or unrelated to the anatomy. But they have high-risk malignant features, but also GI symptoms. Hemorrhage and perforation are particularly rare for all these pre-malignant lesions, but really obstruction, which is kind of the heart of this conversation during this whole session. Obstruction could be of the pancreatic duct with acute pancreatitis, which we think, specifically for IPMN, that's a high-risk factor for malignancy, but also gastric outlet obstruction, which is more common for the non-malignant precancerous problems of the pancreas, which we see quite a bit of. And it's the entire spectrum of gastric outlet obstruction. It's the, minor symptom, foregut symptoms, to the completely, I can't eat or drink anything, gastric outlet obstruction. Now, transitioning to malignant pancreatic neoplasms, we distinguish this between primary and secondary. So the primary would be the pancreatic adenocarcinomas, the most common, presumably 85% of the patients that we see, mucinous adenocarcinomas as a result of the mucinous cystic neoplasms. Then there's the adenosquamous, anaplastic, and acinar cell carcinomas, which bring up the rest of the pie of primary neoplasms. Now, we do also see quite a few secondary neoplasms of the pancreas, renal cell carcinoma being predominantly the most common, followed by melanoma, breast, and lung cancer. Now, for malignant pancreatic neoplasms, indications for therapy would be for primary lesions, resectable disease. We won't go into that. I think that's pretty well established. But also in conditions where you don't have resectable disease or locally advanced unresectable or metastatic disease, surgeons and gastroenterologists play a heavy role in palliation of these patients. We know that quality of life is better with adequate palliation. We know that even survival with metastatic disease is higher with adequate palliation. So it is a pertinent topic for this session. For secondary neoplasms, we focus on aspects that might lead to some presumed survival benefit, single site of disease, a tumor that's shown a less aggressive biology, patients with long disease-free intervals from their primary to the presentation with a pancreatic secondary neoplasm. But again, palliation of GI obstruction, it could be any of the components anatomically that the pancreas affects. Now, let's break this down to site of obstruction. So I think the easiest one and that most people will establish are biliary obstruction. Symptoms are pretty classic, some component of obstructive jaundice with the skin, urinary, bowel changes. Most of these patients will have dramatic nausea, epigastric pain, in some cases fevers and chills when the biliary obstruction is significant. When they're evaluated, typically in an emergency department, maybe in your clinic, scleral icterus, jaundice, depending on the severity of the obstruction or the chronicity of it, you'll see some laboratory changes, the direct bilirubin and LFTs. And then cross-sectional imaging can be varied. You can have dilated extrahepatic, dilated intrahepatic biliary ducts, maybe just extrahepatic. It also depends on timing of presentation. Now, looking at pancreatic duct obstruction, symptoms can be similar but distinct from biliary obstruction. So nausea, again, is significant. Really, it's the pain associated, epigastric and back pain. And then if a careful history could determine steatorrhea as a component. When these patients are evaluated, their abdominal pain seems moderately worse than what you elicit on examination. Their labs can be all over the place. They can be if you look specifically at amylase or lipase, when you're distinguishing between acute and chronic pancreatitis, I think this is the part that emergency physicians always miss. They call you and say, well, the amylase is normal. Well, that doesn't mean anything because they have obvious signs of chronic pancreatitis. And so I can't tell you how many times I get that on a phone call, and I tell them that's kind of irrelevant. I kind of consider the chronic pancreatitis patients as our modern day lepers that people don't know what to do with, don't know how to treat, and they just push them away and say, get out of my emergency room. And so, but at any rate, really the cross-sectional imaging, as we know, is by far the most helpful in the evaluation of those patients to determine where their problem's heading. Now, gastric outlet obstruction is probably if I could choose a favorite one, this is my favorite one. We all love operating on the stomach. It's the most resilient organ there is. I think it's more resilient than the liver, but that's just my opinion. Their symptoms are classic foregut nausea, dyspepsia, eructation, singultus, non-bilious emesis, unintentional weight loss, failure to thrive. I mean, I think anybody can diagnose this, including a medical student in their first rotation. When you examine them, I'm surprised how many of our trainees don't do a good abdominal exam. If you get focused left upper quadrant fullness, I mean, that's the most specific thing that I see in all these patients. They present dehydrated, and then cross-sectional imaging really kind of nails it. You got a dilated stomach with no other real dilation of the alimentary tract. So, small bowel obstructions. I really couldn't find a good picture in my own series of patients of this, but I have so many. I don't know if that's just my management strategies or it's actually the disease process, but they present like any small bowel obstruction, but they have kind of the other components. Typically, this is like acute pancreatitis causing this, nausea, dyspepsia, bilious emesis. They're diffusely distended, dehydrated, and finding transition points at the pancreas is pretty straightforward. And it's not always proximal like this image portends. Sometimes it can be fairly distal. Colonic obstruction, we see quite a few of these. Nausea, dyspepsia, questionable feculent emesis. I'm not a big fan of that. When people say the nasogastric tube looks feculent, I just think they just haven't seen enough of it to know what it really looks like. But at any rate, diffusely distended on examination, dehydrated as well, and again, pretty easy to diagnose. I mean, this picture is pretty nice because there's a pretty big pseudocyst juxtaposed to the colon and making it quite unhappy. So at any rate, now I'm going to finish up this brief overview looking at pancreatic fluid collections. I think this will play heavily in the next few presentations. But we'll start with acute peripancreatic fluid collections, byproduct of acute pancreatitis. And when I say usually incidentally found, this is found in your usual evaluation cross-sectional imaging. It's a product of third space fluid from the severe inflammation. It's pathognomonic for severe acute pancreatitis above all else, especially if the patient has a lack of end organ dysfunction. Usually most of these will resolve without any direct intervention as opposed to managing them medically. And typically we intervene only if it becomes infected over time, most centers using the step-up approach. I drag my feet like crazy for this. We all know that the outcomes are dramatically better, even when developing more severe acute peripancreatic fluid collections with later treatment. But the therapeutic options are all things: percutaneous IR drain, endoscopic transgastric drainage, surgical drainage, and I think these will come up in the next few presentations. Now, I include post-pancreatectomy fluid collection as like a acute peripancreatic fluid collection, and we know this is a byproduct of pancreatic fistula formation. Distal pancreatectomy would be the most common one of these. I think the management of this has changed in the last 5 years. I was bemoaning to a colleague that some of the sessions at this conference have focused on splenic preservation, partial splenectomy versus total splenectomy, and I've never seen a spleen I didn't mind taking out. However, the few times that I've saved the spleen, I've always regretted it. So now you save the spleen, you get a post-pancreatectomy fluid collection, IR can't get the drain in. So in my previous eras, I would surgically drain this laparoscopically. And now I just ask GI to go ahead and drain it transgastrically, and has totally changed that. So maybe I might save a few more spleens as a result of this better approach to drainage in the early postoperative period. These are almost always found because they're almost always symptomatic: fever, pain, leukocytosis, failure to thrive immediately after your surgery. Hopefully they're inpatient, but many of these patients will present a week or two after they're discharged. And intervention when symptomatic, I've had a couple which were essentially asymptomatic that you watched and they could resolve, but most of them at some point are probably going to need intervention. And so again, all the same options: percutaneous drain, endoscopic, and surgical drainage. Walled-off pancreatic necrosis, also a byproduct of severe acute pancreatitis, typically found during surveillance from previous admission for acute pancreatitis. Patients present to your clinic with some failure to thrive. Some of them could get readmitted for signs of sepsis, bacteremia, can't find it. They blame it on the urinary tract infection. The Klebsiella urinary tract infection is probably a Klebsiella from the dead piece of pancreas that's still in. And so people sort of I know a lot of the hospitalists miss that point. Some patients present with GI obstruction. You have this big piece of necrotic pancreas, doesn't allow the stomach to empty well. Generally, they're failing to thrive. So at any rate, endoscopic forms of drainage and necrosectomy, surgical forms are well-known therapies. And then pancreatic pseudocyst, 15, 20 years ago, we operated on all of these, especially if they're persistent after 6 weeks. Now, many of them can resolve without intervention. For the alcohol-specific pancreatitis, cessation from alcohol has a huge effect on the spontaneous resolution of these. Now, since we're seeing more pancreatitis even outside of alcohol, specifically induced acute pancreatitis, some of these won't resolve. Typically, this used to be a surgical-only therapies, but now endoscopic likely is more common for these, especially if there's no real necrosis. Patients just generally do better, but at any rate. So in summary, then it was a very broad and quick review, but benign and malignant pancreatic disease results in obstruction of the GI tract, multiple anatomic sites. The presenting symptoms are similar based on the anatomy of the pathology. The natural history of these pathologies and symptoms is what drives the management. The treatment options are from maximal medical therapy all the way to surgery. And I will tell you just from personal experience, I didn't discuss this much in this presentation, but the multidisciplinary approach to the management of all these patients will help determine what is the best type and timing of which intervention. And I can't underscore that enough. So I thank you, DDW, SSAT, for this opportunity. I guess I'll take questions at the end.
Thank you very much. So we'll switch gears a little bit and talk about the endoscopic management of biliary and intestinal obstruction. Our speaker will be Sammy Ho. He's a gastroenterologist at Montefiore Einstein, and he's been the director of pancreatico-biliary services and endoscopic ultrasound since 2007, and is also the director of Advanced Endoscopy Fellowship at Montefiore Medical Center.
Good afternoon. I want to thank Dr. McCullough and Dr. Dua for inviting me today to speak on, let's see what my title is.
Something in this.
On the endoscopic management of biliary and intestinal obstructions from pancreatic cancer. I always enjoy these combined GI/surgery symposium. I feel like I learn the most in these symposiums from the surgeons. The take-home points from my talk will be that metal stents instead of plastic stents should be placed in patients with biliary obstruction from pancreatic cancer. Uncovered metal stents provide a longer patency than covered metal stents. Biliary metal stents should be placed in patients with pancreatic cancer undergoing neoadjuvant therapy before potential surgical resection. EUS-guided biliary drainage is a reasonable option after failed ERCP in patients with malignant biliary strictures. Endoscopic placement of duodenal self-expandable metal stents is effective in treating obstruction from pancreatic cancer. And finally, EUS-guided gastroenterostomy is superior than luminal stenting for the management of duodenal obstruction from pancreatic cancer. So pancreatic cancer is a very serious disease. It's what I see a lot in my practice. It's the fourth leading cancer-related death in this country, responsible for over 30,000 deaths a year. Because of the late presentation, unfortunately, only 15% of patients are candidate for surgery. Even with surgery, the 5-year survival remains low. With patients without lymph node involvement, the 5-year survival was 25%. With lymph node involvement, is only 10%. So for most of these patients, the main goal is palliation. When we talk about palliation, we start with the relief of biliary obstruction, which can be done via surgical bypass, PTC, or biliary stenting. with biliary stenting, we place either metal or plastic stents. So in this big meta-analysis involving 19 studies, including almost 2,000 patients, so SEMS stands for self-expandable metal stents. Compared to plastic stents, they are associated with lower occlusion rate, less need for re-intervention, and lower incidence of cholangitis. So I would say this meta-analysis is not controversial. We know that metal stents last longer than plastic stents, of course. So in patients with, especially with unresectable pancreatic cancer, I think very few of us now place plastic stents. What about patients who are not quite unresectable but undergoing neoadjuvant therapy before potential surgery? These patients are potential Whipple candidates. In this comparative study, some patients received metal stents and some received plastic stents. And they found that the metal stent placement group was associated with lower rates of re-intervention, delay of neoadjuvant therapy, and recurrent biliary obstructions. So in my practice also, as John knows, I've been working with Dr. McCullough for many years now. Time flies. It's pretty rare that I place plastic stents in patients who are potential candidate for surgery. I always place metal stents. I try to place a shorter metal stents to make his life easier for surgery. What about cover and uncover stents? You would think that a cover stent would provide longer patency, right? It's covered. But is that really true? In this study, looking at 158 patients with inoperable pancreatic cancer with biliary obstruction, 78 received fully covered stents, 80 received cover stents, and they actually found that the median time for stent patency was lower in the fully covered stent group. You would think, why, that's kind of strange, but it turns out that it's the mechanism by which the stent gets occluded is different between covered and uncovered stents. In uncovered stents, you're talking about tumor ingrowth, and as a result of stent occlusion. Now I'm getting nervous because our Michelle Cahaler is here. Oh, thank you very much. He's the godfather of biliary stenting, not because he's older, just because he's that good. Okay. For cover stents, is the mechanism is more like sludge occlusion. So this is a somewhat of a controversial study, showing that the cover stent actually occlude faster than uncovered stents. Now, we're all very good at doing ERCPs, but sometimes obtaining biliary cannulation is just not possible for whatever reason. Prior surgery, periambulary diverticulum, tumor infiltration. So there are a few other options. There's PTC and there's EUS guided biliary drainage. In this study, looking at comparing PTC versus biliary EUS guided biliary drainage, there was no difference in technical success, but EUS guided biliary drainage was found to have better clinical success and lower adverse events. This diagram illustrates the fact that by having the EUS scope in various parts of the stomach and duodenum, we have great access in the pancreas and great access into the bile duct, both the left lobe of the liver and also the extrahepatic bile duct. So hepatogastrostomy is a way for you to drain the biliary tree via the stomach. Here, by having the scope in the for this one is in the duodenum, we're able to access the right lobe of the liver. You inject contrast, dilate the tract, and then place a stent. Now the biliary tree is drained not via the ampulla like we used to via ERCP, but through the stomach into the right lobe of the liver. A choledochal duodenostomy, by having the EUS scope usually in the duodenal bulb, we have a great access into the extrahepatic duct or the main bile duct, inject contrast to confirm location, and a stent is placed. So this is a case that I had. I was asked to do a ERCP on this patient with obstructive jaundice. Looking at the ampulla, you don't even try. It is not going to end up good if you try to cannulate, try to find a bile duct, try to do pre-cut. So what do? You can call IR, do PTC, certainly. You can call surgery to do a biliary bypass, or you can do EUS guided biliary drainage. So now, after looking at this, I take out the ERCP scope. You go in with the EUS scope, inject contrast to confirm that you are in the main biliary tree. You dilate the tract, and you can place a stent. So this stent is not going from the ampulla to the bile duct like we do during ERCP. This is going from the duodenal bulb into the main duct. Most of the time these days, we drain the biliary tree via a stent that is called a lumen opposing metal stent. It really creates a good apposition between the two lumen to minimize the risk of bile leak. There have been numerous studies looking at this, but the conclusion is that this stent is very effective in making this fistula between the bile duct and the lumen of the GI tract with high technical success and clinical success and minimal side effects. So this patient, So this patient, I placed a lumen opposing metal stent in a few weeks before for biliary drainage. The patient came to the ER with what they call cholangitis, which wasn't so. Just to prove that they were wrong, I was able to go through the lumen opposing metal stent into the biliary tree. You can see that it's completely patent. You go in a little bit further, you can even see the intrahepatic ductal system. So this patient does not have cholangitis. The stent is not occluded, and this is just to prove that. Gallbladder drainage. We usually also use this type of stent to drain the gallbladder. Usually I get called by the surgeons who, the 90-year-old patient, cholecystitis in the ER, not good surgical candidate. Can you drain the gallbladder? And my answer is always yes. This is the endoscopy in the stomach. EUS, you see the gallbladder here. And you can place this lumen opposing metal stent draining the gallbladder into the stomach. But I'm not talking about that today. I'm talking about using as a rescue therapy. A patient with obstructive jaundice, and for some reason you cannot gain access into the bile duct via ERCP. Well, what about draining a gallbladder? Would that work? Sometimes. In fact, I think most of the time. In this study, looking at draining the gallbladder as a rescue therapy, 48 patients with obstructive jaundice, ERCP failed to gain biliary access, and they placed a lumen opposing metal stent into the gallbladder to kind of indirectly drain the biliary tree. Success rate technically 100%, clinical success 81%, and the mean percentage of decrease in bilirubin after 15 days was 66%. So this is kind of what I do in my practice also. Why not? When a patient, for some reason, you cannot gain access into the bile duct via ERCP, a lot of times, not too surprisingly, the gallbladder is very distended. And I usually just place a stent in the gallbladder to see if the biliary obstruction will be relieved indirectly. And I would say, I don't have a personal data, but I would say that is usually successful in my practice about 80% of the time. Let's switch gear real quick about duodenal obstruction, which pancreatic cancer can cause also. Endoscopically, we can do a couple of things. We can place luminal stent, or a technique that has been developed probably in the last few years, more commonly done, EUS guided gastroenterostomy or EUS guided gastrojejunostomy. Duodenal stents are usually always made by nitinol, which is a nickel titanium alloy. 23 millimeter diameter is a typical stent width. Comes in different length. And because the delivery system is only 10 French, it can actually go through the working channel of a scope. So you can see the stent being deployed endoscopically. So this is quite easy to do. But more commonly now these days, we do a lot of the EUS guided gastroenterostomy. In this study, comparing laparoscopically done GJ versus EUS guided GJ, they both have high success rate, but you can tell they, not too surprisingly, the adverse events was lower in the EUS group. Duodenal obstruction. The way we do this, we pass a wire beyond the obstruction, and I use a nasal cystic tube that goes past the wire, and I usually distend the distal bowel with contrast, and then you can place a stent between usually the stomach and the distal bowel. Here you can see, this is what you want to see. You can look through the stent. You want to see the jejunum through the stent. You don't want to see the liver or anything like that. And this is the stent here, a gastroenterostomy or jejunostomy. Which one is better? Well, comparing luminal stenting with the US GJ, in this study, most of them were due to pancreatic cancer causing this duodenal obstruction. There was no differences in the technical and clinical success, but the EUS GE had a higher stent patency at 3 to 6 months. So to summarize what I do in my practice, I think if you can do an EUS GJ, I would prefer that, but it is more challenging to do, and a duodenal stent is a little bit easier to place. So depending on clinical situation, you usually can send a patient for both procedures. But you know, if you have a 90-year-old with obstruction, I try not to go crazy and try to maybe just put a duodenal stent and get out and not cause any major problems. So, going back to my take-home points, we talked about metal stents should be placed in patients with biliary obstruction from pancreatic cancer. This is not controversial. Of course, metal stents last longer than plastic stents. We talked about maybe a little bit of a surprise that uncovered stents provide a longer patency than covered metal stents. We talked about patients who are maybe potentially undergoing Whipple, who are undergoing neoadjuvant therapy, that maybe metal stents should still be placed as opposed to plastic stents. We talked about EUS guided biliary drainage, which is a good option after failed ERCP. We went over duodenal luminal stenting is effective in treating obstruction from pancreatic cancer. And then the last few slides, we went over EUS guided gastroenterostomy is superior to luminal stenting for the management of duodenal obstruction. One last slide I want to show you. I had a case last Friday before I came to DDW. You can see here, this is a biliary stent, obviously, and you would think this is a duodenal stent. You would think so, but it's not. This patient has a pancreatic cancer and came with colonic obstruction. So it was a hepatic flexure obstruction due to tumor infiltration. This one did not come from John on a late Friday before DDW. It came from another surgeon. So, but we did place this is a colonic stent. So this is just a cool picture I want to include in the last minute before I came. Thank you for your attention.
Next, we have surgical management of biliary and intestinal obstruction because of pancreatic head disease. We're lucky to have a local expert, Dr. Jin He, from the Johns Hopkins University School of Medicine. He is the division chief of HPB surgery there and well known for his technique in pancreatic surgery in open, laparoscopic, and robotic disease.
Excuse me. Good afternoon. Thank you for the invitation, for the opportunity. Actually, I was a little bit worried to follow Dr. Ho's talk in the beginning. Now, after listening to his talk, I feel like much more relieved because I would say I agree majority of his take-home points. So I'm going to just talk a little bit from a surgeon's perspective, how we manage patients with malignant biliary and intestinal obstruction. So I'm trying to narrow this discussion a little bit, only focus on patient with pancreatic head cancer. So I think the key point here is all about the patient selection. In the next 10-15 minutes, I'm just going to focus hopefully more on how we select a patient for a different approach from a surgeon's perspective, and hopefully introduce some papers, data, which I just reviewed for the preparation of this talk. So biliary obstruction or obstructive jaundice, duodenal obstruction or gastric outlet obstruction, both are common presentation in patients with pancreatic cancer. But the key here is knowing the etiology of the obstruction is very critical. Every patient with pancreatic cancer, they present with different stage. Patient coming in with resectable pancreatic cancer with obstruction should be managed completely differently from patient with advanced or metastatic pancreatic cancer. So the common practice in managing obstructive jaundice, the GOO patient with advanced pancreatic cancer, typically a so-called double bypass, which is gastric jejunostomy and hepatic jejunostomy. And this is typically true in the past without effective chemotherapy. Nowadays, we're facing less and less patients in this situation. So the common scenario in surgeon's practice is you take a patient to the OR, plan for a Whipple operation for resectable pancreatic cancer, and during the surgery you find the tumor is way more infiltrated. You cannot do the surgery. So changing diagnosis, and in this kind of scenario, that you probably will consider a bypass procedure. And gastric jejunostomy can definitely relieve gastric outlet obstruction or impending GOO. Now, a lot of patients nowadays already presented with a metal stent in the biliary tree. Those patients we typically don't even consider HJ due to the technical challenges. Now, for patients present with GOO with advanced pancreatic cancer, there are many different approaches. From a surgery perspective, if it's only GOO, gastric outlet obstruction, you can consider either open surgery or nowadays, I think the standard should be a minimum invasive approach. Any surgery has its own complication, although laparoscopic GJ is a very straightforward procedure. You can still have potential risk of infection, leakage, delayed gastric emptying for unknown reason happens not uncommonly after a laparoscopic gastric jejunostomy. For endoscopic approach, as Dr. Ho has nicely presented to all you, there are many different approaches: duodenal stenting, endoscopic GJ, and those procedures, it definitely can be safely done with experienced hands, but also has the same potential complications such as leakage and stent migration. So where are the data to support different approaches? So this is one of the very early surgical publication from the Hopkins group, looking at the role of prophylactic GJ for patients with unresectable periamputary cancer. And so this is a small randomized clinical trial looking at GJ versus no GJ, prophylactic. So clearly looking at the outcome, prophylactic GJ significantly decreased the incidence of late GOO. This is another study, a little bit more recent, but it's still almost like 20 years ago in the surgery literature. This is a study from the Dutch group, another prospective randomized clinical trial showing a double bypass, which is GJ and HJ, is better than a single bypass, which is only relieve the biliary obstruction. The point is, what they try to show here is the prophylactic GJ can also significantly decrease the incidence of GOO without increasing the complication rates. Now, looking at the endoscopic approach. Endoscopic approach here is a really good study, very recent paper in Lancet, basically compare endoscopic GJ versus duodenal stent. If you look at the curve on the right side, as Dr. Ho showed you earlier, compared to the duodenal stent, endoscopic GJ has a better patency for patient with unresectable malignant GOO. Again, the patient should have unresectable disease. So endoscopic GJ should be considered as a standard. Now, which one is better, endoscopic GJ versus surgical GJ? Now, honestly, I couldn't find any really high-level publication from Surgery Journal. So this is a paper from gastrointestinal endoscopy. This is, again, a retrospective large multi-center experience. So basically, they compared endoscopic GJ versus surgical GJ, but only for the patient with unresectable malignant GOO. The primary outcome is looking at the time to resume oral intake, the length of stay, and the mortality. Essentially showing the outcome between surgical GJ and endoscopic GJ is similar. But again, the endoscopic GJ, although patient does not need to suffer from surgical incision, it's compared to surgical GJ, which is, again, in surgeon's perspective, is a definitive approach. Endoscopic GJ for patient with unresectable malignant GOO offer the same amount of palliative benefit. Now, switch gear a little bit, looking at the malignant bile duct obstruction. There are many different approaches. From surgery perspective, you can do Roux-en-Y, choledochal or hepatogenostomy. You can also consider, for those patients with extremely short mesentery, you can consider a choledochal duodenostomy. Now, the majority of those cases can be done with a minimally invasive approach if the center has this kind of experience. Now, obviously, doing any surgical biliary bypass carries its own risk, bile leakage, vessel injury. But this is considered as a definitive approach for patients who need a biliary bypass. The non-surgical biliary drainage, in my mind, is basically divided into two major categories. Now, traditionally, if possible, you can consider ERCP. If failed ERCP, the IR will typically consider PTC. Those two procedures are considered anatomic biliary drainage because you still maintain the anatomy of the biliary tree. Now, as Dr. Ho showed you earlier, that a lot of premature endoscopic procedures in the last 5-10 years developed, which is considered EUS guided biliary drainage. In my mind, is considered non-anatomic drainage because you create a new fistula between the stomach and liver or between the duodenum and the biliary tree. Now, those will have impact to patients, especially with patients with resectable pancreatic cancer. Now, the guideline is basically saying, I'm here quoting a guideline from gastroenterology. It's basically saying for patients with resectable disease, not every patient needs a drainage. Again, drainage before the surgery not only increase the surgical complication rate, but also increase the infection rate. Now, obviously, for patients with resectable pancreatic cancer who needs neoadjuvant chemotherapy, who needs a tissue diagnosis, this is a common practice to get a tissue diagnosis and biliary drainage. But for straightforward cases, not every single patient will need a biliary drainage before the surgery. Now, for patients with unresectable disease, this should be considered as standard endoscopic drainage, whether it's metallic stent through ERCP, or for some patients, you should consider EUS-guided non-anatomic biliary drainage. Now, ERCP has been standard for a long time, has a very high success rate, but also carry a lot of potential complications. To surgeon's perspective, if ERCP causes pancreatitis, bleeding, perforation, cholangitis, that's a disaster to manage. On the other side, patient with ERCP placed metallic stent can give the patient adequate drainage and help those patients go through the neoadjuvant chemotherapy. Now, EUS guided non-anatomic drainage, as you showed there are some earlier videos, I would say those procedures are probably nowadays are routinely done with advanced endoscopic team in major academic centers. But the key here is about the patient selection. It's hard, to talk about whether the primary tumor is resected or not without surgeon's involvement. So if a patient come in with obstructive jaundice, a large tumor in the head of the pancreas, if ERCP fail, what is the next step? Is that a PTC? Is that EUS guided non-anatomic drainage? I think that warrant a discussion between the GI team and the surgical team before any procedure happens. Now, as Dr. Ho showed earlier, there are many potential advantages for EUS guided anatomic biliary drainage. Longer patency of those stents, much lower chance for post-procedure pancreatitis. Patient in general has much better quality of life compared to percutaneous drainage. But there are also other potential consequences for those patients who had this kind of non-anatomic biliary drainage. There's some paper to quote here to compare different approach for biliary obstruction. Now, as I mentioned earlier, this is a paper compare ERCP versus EUS guided biliary drainage here. Again, I know you go through all the details here. In general, EUS biliary drainage has much lower reintervention rates, higher patency, should be considered as a sort of a standard approach for patients with unresectable pancreatic cancer. This is another systemic review and meta-analysis compare these two different approach. But this kind of publication is not much detail to look at the etiology of those biliary obstruction. There's very few details talking about the staging of those malignant disease and the potential for surgical resection down the road. This is an interesting study. So basically compare endoscopic ultrasound-guided biliary drainage versus, endoscopic ultrasound-guided choledochoduodenostomy versus hepatico gastrostomy. Both are considered non-anatomic drainage, but this study clearly demonstrated hepatico gastrostomy is equal to choledochoduodenostomy in terms of the success rate and drainage and relieve the bile duct obstruction, especially when you look at those complication rate. Now, EUS guided biliary drainage versus ERCP. This is a very small study. Again, retrospective design, 87 ERCP versus 58 EUS guided biliary drainage. Although this is a very recent publication, you can see here, compared to ERCP, EUS biliary drainage, the adverse event is similar or lower. But on the other side, they have much less incidence of reintervention. Now, PTC, as I mentioned earlier, is considered anatomic drainage. Now, whether this is considered standard of care if ERCP fails or not is still very controversial and debatable. Now, I can only find one paper to compare this to, EUS guided biliary drainage versus PTC. If you look at the so-called success rate here, they are very similar. But again, how do they define the success? It's still unclear to me. A paper, published with no surgeon's perspective here, it's hard to argue what they define as a clinical success rate. But on the other side, you do notice the PTC, the cost of the PTC is much higher compared to the EUS guided biliary drainage. This kind of review, it's hard to argue the data, but on the other side, the data here presented has very minimal information about tumor staging and totally lacks the impact, lacks the perspective from surgeons' experience. So how this kind of procedure will impact the surgical resection later after biliary drainage remains unknown. My current practice, so again, I think patient selection is the key. Before any drainage happen, a multidisciplinary discussion, I think, is very important. If the patient is a surgery candidate or potential surgery candidate, how the drainage happen will definitely impact the surgical approach. In my practice, patient with resectable pancreatic cancer who needs preoperative chemo treatment, I agree with Dr. Ho, a metal stent, whether it's endoscopic or percutaneous, is very effective. But for patients with advanced pancreatic cancer, I do believe EUS guided non-anatomic drainage is appropriate. Now, based on the guidelines, especially for those patients with life expectancy less than 3 months, this kind of procedure helps those patients in terms of quality of care and the drainage efficiency. Now, in my institution, our IR team also routinely perform percutaneous biliary drainage with internal stent. So those patients do not carry a tube outside the skin. So their quality of life is also very reasonable. Some patients after percutaneous internal stent placement, they responded to chemotherapy really well and end up with robotic Whipple procedure. We've seen that several times before. So again, patient selection is the key. Communication is critical here. I'm going to stop here. Thank you for your attention.
Wonderful questions. I know you're dying. We're going to hold questions to the end. We have one more speaker, and actually, Dr. He already had the privilege of introducing our next speaker, Dr. Amy Tyberg, through many of the studies that he presented in his work, looking at ERCP and EUS biliary drainage. So she's going to come up and present the timing and options for endoscopic pancreatic fluid collection drainage. She is an associate director of endoscopy for Hackensack and Meridian Health Systems in New Jersey. They were like all your papers.
I like this topic. Anyway, thank you so much to the course directors and the moderators for inviting me to speak today. So I will be talking to you about the timing and options for endoscopic pancreatic fluid drainage. If I can get my slides to go. Okay. So I thought I'd start off with a case. This is actually a case one of my partners saw right before coming to DDW, a 73-year-old male, past medical history, just notable for multiple sclerosis, who presented with abdominal pain. His pertinent recent history was that a month prior, he had presented to the hospital with gallstone pancreatitis, choledocholithiasis, and underwent ERCP with biliary sphincterotomy, stone extraction, and stent placement. And he was treated conservatively at that time. And when he presented to the hospital, he was quite ill. He was febrile, he was hypotensive, and he was requiring pressor support in the ICU. And when cross-sectional imaging was performed, it showed that he had a large 13-centimeter pancreatic pseudocyst, which you can see here on imaging. So when we think about patients like this is a pretty classic story for a patient that's going to come in with a pancreatic fluid collection. Really, the mainstay of therapy for these patients is drainage. And as was mentioned earlier, we start with the minimally invasive approach and generally do a step-up approach, and that generally means starting with endoscopic drainage as the initial treatment of choice. And when we talk about pancreatic fluid collections, I know this was touched on earlier, I just want to emphasize again, it's really only the symptomatic collections that need to be intervened on. Obviously, in this patient who's very sick and septic with infection, this is definitely a symptomatic collection that requires intervention. But some of the other symptoms that patients can present with include abdominal pain, early satiety, nausea, vomiting, jaundice, or complications of their collection, such as infection and some of the other obstructive etiologies that we spoke about in the previous lectures. And when we look at the data to support the fact that we start with an endoscopic approach, there's numerous studies. There's so many to choose from. I picked one of the larger studies here. This was 192 patients, just looking at the safety and efficacy of endoscopic guided drainage of pancreatic fluid collections. And you can see pretty excellent technical success, clinical success rates, and relatively low rate of adverse events. Additionally, when you look at comparing endoscopic drainage versus percutaneous drainage, this is a retrospective study, but you can see again, no difference in technical success and adverse events, but the endoscopic arm did have fewer interventions, shorter hospital stays, and decreased number of follow-up imaging studies, which may not seem significant, but these patients can be getting quite a lot of CAT scans and they can add up over time. So that is actually a significant advantage. And this is actually a randomized trial a couple of years ago, 2013, so actually quite a while ago now, but still important. This was 40 patients that were randomized. And again, technical success, adverse events, similar between the two groups, but there were some benefits of the endoscopic arm, including shorter hospital stay, lower costs, and better mental health and physical health component scores. So when we, let's see if this will play. So this is what it looks like here. Here you can see the fluid collection on endoscopic ultrasound is this anechoic area here. We're using a lumen opposing metal stent that was just mentioned earlier. And here you can see this is the distal flange being deployed right in the middle of the collection. You can then pull this back and use it almost like a retractor, and it allows you to anchor that collection right against the wall of the GI tract. In this case, it's the stomach. And then you're deploying the proximal flange in the GI lumen. And you can see the endoscopic image on the bottom of your screen there. I'll give you a little suspense. There you go. And in this particular patient, to get back to our case, this is exactly what was done. You can see the endoscopic image of the fluid collection. You can see the stent being deployed under endosonographic visualization, and then the endoscopic images of the, oops, sorry about that, of the lumen opposing stent. And in this case, we put some plastic double pigtails through, and I put the picture of the purulent material right in your face, front and center. One, because I think it's far enough after lunch that that's acceptable to place. And two, that is my absolute favorite of all the therapeutic US procedures. When you get this flush of purulent material draining, you can already imagine how much better the patient is feeling as that's draining. It's very satisfying. So I just wanted to change the case just a tiny bit and talk about if this patient had presented with a CAT scan like this, for instance, where it's not just a pseudocyst, but there is the presence of some solid debris and necrosis, which I don't know how well it came out on the slide, but there's where the arrows are pointing, there's some solid debris, then drainage alone is not going to be adequate for this patient, and you need to think about not just drainage, but also necrosectomy. And the way that's done is the same type of EUS-guided drainage by placing a stent, but then the additional step of actually taking an endoscope, advancing it into the collection, and mechanically grabbing and removing all the debris in there. And that can either be done by dilating the fistula tract to allow the scope to go in, or nowadays in the era of lumen opposing metal stents, you can actually just pass the scope directly through the stent multiple times and remove the debris piece by piece. And while this sounds relatively simple, it is what we say not for the uncommitted, because it generally requires multiple sessions. These patients have long inpatient courses. and there are the potential for significant complications, even in the most experienced hands. So it is important to always have a multidisciplinary approach when embarking down this pathway. And I just wanted to show again some of the data specifically about walled-off necrosis. This is a landmark study. This is from the New England Journal of Medicine. Again, a relatively older paper now, but still, I think, a critical paper showing that there's clear benefit of a minimally invasive approach and stepping up to more invasive as needed, including less major complications or death in the minimally invasive arm. This is another landmark trial. This is from JAMA, randomized trial, small numbers, but again, showing that there's benefits to the minimally invasive approach, starting with the endoscopic approach and then stepping up as needed. And now we even have a more recent randomized control trial. This was a single center study, 66 patients. And what they found was that there was no difference in terms of efficacy or adverse events, but where the difference really was in morbidity. And you can see that the fistula rate was dramatically different between the surgical group and the endoscopic group. There were more major complications and worse quality of life scores. So just more evidence that starting with minimally invasive and working your way up is the approach. And here's what it can look like when you're doing drainage of walled-off necrosis. You can see that instead of just nice purulent material, you have some solid debris here that you can see through the stent, and this is what necrosectomy can look like. Here we are actually with the scope in the cavity. You can see all the necrotic material is kind of on the superior portion of the image. Everyone has their favorite necrosectomy tool, none of which are actually designed for necrosectomy. So like most of the therapeutic EUS procedures we do, we are adapting devices that were designed for other indications to use as what we need them for. In this case, it's a Rothnet. I personally like the trapezoid basket that's used for gallstones, and I think it works very well to grab necrosis as well. There's also new something called the endorotor, which was actually designed for tissue resection, but has found its home, I think, as a really excellent necrosectomy tool. And you can see, multiple sessions are often required. Each time there's less and less necrosis. And I don't think I can fast forward here. It's almost at the end, but you can see as you clear out all the necrosis, you see more and more healthy granulation tissue. And once you have all the necrotic material removed, then that collection will start to collapse and heal. And here's the final image where you can see no more necrosis and just beautiful clean tissue all around. And so now it will start to heal. So when our patient started like this, and then slowly but surely, eventually cleaned, and the patient did very well. So I think, there is a lot of definitive data when we're talking about pancreatic fluid collections, but there is also some variation and some variability, and I think some issues that still the jury's still out on, and I'll just go through a couple of them. One is there's lots of different stents that can be used for drainage, and I just put a summary of what you can see here. You have anywhere from plastic double pigtail stents to the fully covered self-expanding metal stents, which again designed for the biliary tract or the esophagus, but we use for other indications as we need them. And now probably the most common stent that's used in this, which was actually designed for this indication, which is the lumen-opposing metal stent. You can see the sort of the two flanges on either side, so it creates great apposition in the image at the bottom. You can't see my pointer, but it's in the bottom center of the screen. And when you're deciding which stent, there's a lot of factors to consider. The type of the collection, is this purely a pseudocyst? Is this walled-off necrosis? If you know that down the road you're going to have to do a necrosectomy, you might opt to put a lumen-opposing metal stent from the get-go, because then you can advance your scope through it more easily, whereas if it's just purely a pseudocyst with fluid, you might opt for just a plastic stent. If there's infection there, that's generally going to make the fluid thicker and harder to drain. So again, you might want to go for a bigger diameter stent. The size of the collection, these lumen-opposing metal stents require a significant amount of space in order to deploy. So if you have a small collection, you might want to choose a different type of stent. And of course, the distance between the GI lumen and the cyst, if it's more than 1 centimeter, you can't use a lumen-opposing metal stent. You may need to choose a fully covered self-expanding metal stent, for instance. There's also some questions about whether you should actually use a plastic stent with your lumen-opposing metal stent when you're draining these collections, and that there's been a lot of data back and forth. This is a recent study, actually from earlier this year, a recent meta-analysis, 3 studies over 200 patients, and what they showed was that there was really no difference in clinical outcomes, but the procedure duration when you're using a lumen-opposing metal stent versus a plastic stent is significantly less. So, as I said, lots of factors to consider, but when you're comparing lumen-opposing metal stents versus plastic stents, there may be benefits to going directly to lumen-opposing metal stents. And I'm sorry, and this is the study comparing lumen-opposing metal stents with or without plastic double pigtails. Before it was lumen-opposing metal stents to plastic stents alone. And again, here, when you add the double pigtail stent with your lumen-opposing metal stent, you actually see that there were fewer overall adverse events. Other factors to consider is, which patients will require necrosectomy. There is now a novel classification system, which is called the Q&I score, which has come out of the group at Mayo that tries to risk stratify patients into lower risk or higher risk patients, depending on the number of quadrants that the pancreatic necrosis involved, the amount of necrosis that's there, and whether or not there's infection or not. And what they found was that in those with more than 3-quadrant involvement, or 2 quadrants with more than 30% necrosis, or 1 quadrant with more than 60% necrosis and infection, they required more necrosectomies, longer hospital stays, higher readmissions, and a longer time to resolution. So a nice prognostic indicator. And there's actually been a couple abstracts here which have prospectively validated this score and found it to be a nice prognostic indicator. When should necrosectomy be performed? This is also a relatively recent study, a randomized multi-center study that looked at whether patients should have direct necrosectomy the same session that they have their drainage procedure versus doing a step-up approach where you do your drainage procedure and then perform necrosectomy down the road as needed. And what they found was that in the group that had necrosectomy up front, they had fewer reinterventions, they had better clinical improvement, shorter hospital stays, but no difference in adverse events. So the conclusion was that necrosectomy at the time of the initial placement has a faster rate of clinical improvement and a shorter hospital stay. So interesting things to think about, certainly when we're approaching these patients. And I know that our traditional thought process has always been we need to wait at least 4 to 6 weeks after the pancreatitis episode before proceeding with drainage, but this is a study that actually challenges that a little bit. An analysis, of 6 studies, 630 patients, looking at those that were drained less than 4 weeks versus the standard more than 4 weeks after the inciting event. And what they actually found was that both groups had similar technical success and clinical outcomes. So more food for thought. The last 2 things that I think are important when you're approaching these patients, nutrition is a key to success, and it's while you're draining the collection, you also need to think about the nutrition of the patient. We all know that the enteral feeding is the preferred approach. This was a Cochrane review from 2010 showing that there's clear evidence that enteral feeding is the optimal method. And then, of course, don't forget the pancreatic duct. If you have a fluid collection and you drain it, but you don't address the pancreatic duct, you take out that stent, and it's just going to reaccumulate because you haven't actually addressed the initial problem. And there's a lot of studies, I won't go through all of these in the interest of time, but that show that if you ignore the pancreatic duct, you can have increased severity of pancreatitis, more recurrent attacks and long-term complications, and of course a decreased rate of resolution after drainage. So I will end with a slide like this. These pancreatic fluid collections can be very complicated because of the number of medical specialties that get involved, and I think it just emphasizes the point that has been mentioned through every one of our lectures, that a multidisciplinary approach is really critical to optimal management of these patients. And this is the algorithm that we used at my institution, that we developed with our surgeons, with our radiologists, with our intensivists, so that all of us were on the same page and we could really manage these patients in the most optimal way. And I will end there. Thank you so much for your attention.
Oh, come on. I thought we asked pretty nicely when we asked you for the septic patient for endoscopic drainage. Can I have the speakers come back to sit on the panel, and then now we'll open for questions at this point. Thank you for holding them. Yeah.
So I want to thank our surgeon for being so brave in coming into this section.
I was worried. I look at the whole room. I don't see many surgeons.
I know. That's why I actually admire your bravery. Thank you for being here. And actually, I really enjoy your talk. You went over the historic and the conversion slowly of some of those procedures that used to be done surgically, slowly shifting to EUS-guided procedure. And I think we all understand the concept, the very important concept of respecting the anatomy. And as a surgeon, this is a priority for you. One question that I have for you is, in those patients that seem to be living longer than 3 months and underwent chemoradiation, in your institution, you use PTBD. Can you please expand on that? Why would you do that?
I'm not saying everyone get a PTBD. I would say ERCP, PTBD, in my mind, is considered, the patient still maintain the biliary anatomy. And so if those patients in the end become a surgery candidate, the surgery, the difficulty itself is not going to be altered. But if the patient already had, hepatogastroscopy, that's like an altered anatomy for the patient. If I do the surgery again, the difficulty of the surgery will be significantly increased.
So the PTBD is for the altered anatomy?
Right. So if we would do the percutaneous drainage, patients still maintain the normal anatomy. They don't have another fissure between the liver and the stomach, right? So if the patient would never get the surgery, I'm totally for, hepatogastroscopy or, choledochoduodenoscopy. I'm totally for it.
Yeah.
Right. But, especially compared to, choledochoduodenoscopy versus hepatogastroscopy, I would rather prefer a fissure in an area where I'm going to remove regardless. I don't care. But if I do a Whipple on the other side, I have a fissure between the stomach and liver, what am I going to do with that?
So what if I tell you that we've sent patient with a hepatogastrostomy for Whipples, and the surgeon didn't even notice that the patient had a hepatogastrostomy?
I see that kind of patient quite often in Baltimore. And some patients, as you said, if they do it right, I don't notice difference. Some patients, because of either leakage or migration or multiple stents, and I couldn't even do it a minimally invasive surgery. I have to do a traditional open surgery. And I have, when we do the open surgery, we have to retract the left liver up to see the hilum of the liver for reconstruction. And you already have a fissure there, and it just makes things harder.
Yeah.
And then on the other side, you do a hepatogenostomy after Whipple, that's a fresh anastomosis. On the other side, if that old fistula has any issues, it's going to leak from the other side. I've seen all kinds of complications.
So you're talking about the case where we screwed up. That's what you're talking
I'm
about.
talking about those patients who eventually need the surgery.
Okay.
And that's how I see those complications.
But if we offer you a nice and clean, smooth hepatogastrostomy, can that make you happy?
I'll be very happy about
That's
it.
great.
Now,
then
just,
we are delighted.
just to be clear, what do you mean by hepaticogastrostomy? You mean to the common hepatic duct or to the left system?
So I'm talking straight drainage from the left hepatic duct into the stomach.
Okay.
That's it.
All right.
And we've
And also
had
depends on where in the stomach. We
Yeah.
had a couple of patients recently. It's at a G junction, the left liver has a fistula there.
Yeah.
So every time the patient eat, the food just go into the liver, and
no,
the patient come back with
we,
cholangitis.
we always stay away from the G junction unless there's no access to the left hepatic duct below the G junction. It has to be an unresectable patient. But if it's
That's the key,
resectable,
unresectable patient.
yes. But if the patient is resectable, then what we do, we go below the E junction, we tip up, and we make sure that we get the most superior branch of the left hepatic duct, below the EG junction. And those cases, they don't seem to bother the surgeons.
Actually, at our institution, we also do ERCP followed by IR PTBD in resectable disease. And a lot of times that's because we're thinking of like the fact that they'll get neoadjuvant chemotherapy and sometimes the inflammation or the tumor response improves. And then we're able to convert, through wire access, the PTBD back to like internal stent, right? So our GI colleagues and our IR do like a rendezvous procedure, and then you're kind of back to sort of normal anatomy with the regular stent that we had hoped for. It just wasn't anatomically possible. But maybe I can ask Dr. Ho, out of the 3 options that you proposed, which was the transduodenal straight to the bile duct, that ERCP, versus transduodenal, like the axios into the bile duct, versus just draining straight to the gallbladder. If you have those 3 options, which one are you going to do, like typically if both the gallbladder and the bile duct are dilated?
Well, the gallbladder is that's my rescue therapy. That's plan B. So I always like to drain the bile duct via the bile duct. So I thought that. So my first choice after a failed ERCP is always a choledochal duodenostomy. I know that Michelle prefers hepaticogastrostomy. I think that might be personal preference, but I would also, so in my mind, it'll be choledochal first, hepatogastro second, and gallbladder third.
So we hear a lot about the lumen opposing stents. When are they not appropriate or not indicated?
I think a lumen opposing stent is not meant to be in forever.
Yeah.
There has been cases of hemorrhage when the cyst collection is collapsed and the opposite wall can erode into the cyst, into the stent. So I think one indication where it's not a good candidate will be a patient who is not a good at follow-up. Then under those circumstances, I think it's important for us to still learn how to place plastic stents. And I think fellows do need to learn how to place plastic stents. I had a fellow who was trained with me for the year, and he went back to Puerto Rico, and where Axial is not available. And he just said to me, "Sammy, you never taught me how to place plastic stents to drain this cyst." I said, "That's my bad, because Axial is so easy to place." So those are two good reasons to still know how to place plastic stents.
So to follow up with that, sorry. So you're doing it in a palliative setting, someone has unresectable pancreas cancer, whether it be metastatic or locally advanced. You place this axio stent to their bile duct. Do you remove that a couple weeks later and this fistula stays in place, or do you replace the axios? How does that work?
I usually place these stents in patients who are not resectable. In terms of the gallbladder, I have approached a couple of surgeons at our institution to see it would bother them if the patient was going to undergo Whipple, and I was told no. What do you think?
That one, no, I don't think so. But I'm talking about the patient who's never going to go to surgery who gets this lumen opposing stent. How do you manage that stent when you just said there could be complications like bleeding after the fact?
Oh, I see what you mean. Yeah, those patients, I always placed with the underlying cancer, I usually do not remove those stents. In terms of have I encountered complications with those stents in patients who have, lived longer time? Not yet. Michelle, have you?
This is a very important question. I mean, in malignant disease, obviously, the idea is always to make those patients comfortable until they die, so you don't see them. But to go along to what Sammy was saying, in patients that may have benign diseases or in whom is going to live longer, you may want to place a double pigtail, because oftentimes when the biliary tree is decompressed, the axios is going to basically oppose against the opposite wall of the bile duct, and then that can actually create an obstruction. So talking to Manolo, who has one of the largest experience in this, he's the one who actually advocated from pretty much everybody to place a double pigtail that will disimpact the axios from the opposite wall of the bile duct. So this is what we do in those benign diseases.
I'll just add, there was recently a publication from the Milan group specifically looking at occlusion of these lumen-imposing metal stents in choledochal duodenostomy, and one of the key takeaways that they mentioned is that you must treat the gastric outlet obstruction concurrently with the biliary obstruction, because otherwise you're almost certainly going to have occlusion of those stents and the patient's going to require repeat intervention. So while you don't necessarily need to go and replace these stents in someone with malignant disease who doesn't want to come for repeat interventions unless their symptoms suggest that they're reoccluded, you want to maximize the chance of patency, and one of the key features is to treat the gastric outlet obstruction.
So they're going to get another axios, like a GJ axios at the same time.
There's a lot of centers that actually will do both at the same time, whether it's hepaticogastrostomy and GJ or choledochal D and GJ at the same time. And we've done that, and it's definitely feasible and saves the patient coming for two different procedures.
When you do the axios for the GJ, are you intending to do those really when they're that palliative that you're only intending to drain the stomach secretions? Like you don't really, because I imagine that one would be hard to exchange more than the ones in the bile duct.
It's actually not. So it's actually the opposite for me. If they have a shorter life expectancy, like 2 or 3 months, I'll often opt for a duodenal stent because it'll work for the short term, and then you don't have to worry so much about stent occlusion. At 6 months, 50% of those stents are occluded. So for me, if the life expectancy is longer, like if they're just starting chemotherapy or their disease is not end stage as of yet, then I'll actually opt for a GJ as opposed to an enteral stent. And the exchanging the GJ stent is actually not as difficult. Once the fistula has matured, which we know happens around 2 weeks generally, you can actually remove that stent and the fistula will stay for enough time that you can put a new stent in, and you don't need EUS. At that point, you can just use a therapeutic scope and deploy a new stent.
I think from the patient perspective, the gastrojejunostomy is much higher quality than a duodenal stent. Those patients don't complain of eating problems, the specific diets they have to be in, so their quality of life, and I'm not sure I haven't seen that it's actually been formally studied, but from patients, anecdotal discussions that I've had with them, they find that the gastrojejunostomy is much more effective than even the duodenal stent.
Yeah. There's actually a really interesting abstract presented yesterday that looked at skeletal muscle in patients after enteral stenting versus GJ, and that they had much better maintenance of their skeletal muscle with the GJ than the enteral stenting, which they said was basically a way to measure their nutritional status between the two interventions.
So in just a couple more minutes, I wanted to bring up a challenging scenario to Dr. Tyberg and Ho. You're doing your necrosectomy, you've got your net or whatever your preferred tool is in there, and all of a sudden you have a significant amount of bleeding, because we know the splenic vein and artery are in that area. How does that go, and what's the move in the endo suite, and when is surgery notified? And then, Dr. He, what does the surgeon say and do at that point, if anything?
You want to start, or you want me? Up to you. Go ahead.
Well, the mic is in front of you. But it can happen. It hasn't happened to me yet, but I'm always waiting for the first time. But as you know, I try not to do this type of procedures late at night by myself. When I'm doing these necrosectomies, John, I always let you know that I'm doing these today. I want to make sure there's a surgical backup. If I do hit the splenic artery, I'm sure it will happen at some point in my career. Yeah, there's nothing much I can do at that time. Hopefully, I will have the backup with the IR and surgery to bail me out, like you guys always do.
Are there techniques in the endo suite to help manage things? Because you all see bleeding a lot from the stomach, from like a polypectomy or something like that. Is that an option? Those options available or not?
I think it depends. If it's just a little bit of minor bleeding, then yes, we can use a lot of endoscopic options to help. And now we have things like hemospray and Puristat, which are, buy you time and can help with clotting until you can find a more definitive solution. I find when you have bleeding that's really significant bleeding during a necrosectomy, the first thing to be worried about is a pseudoaneurysm. So for me, I'm doing something temporizing to stop that bleeding, whether it's packing it with plastic pigtails, using some kind of spray or powder to sort of stop the bleeding temporarily, and I'm sending them for CTA and calling my interventional radiology colleagues to embolize them.
Okay, so Eugene and Jen, the next move for them is CTA.
Yeah, I've seen this quite a few times. I can say it all depends on how aggressive we do the necrosectomy. And in general, if it's arterial bleeding, that going to the IR is probably the choice because you take the patient to the OR, there's nothing else you can do either. It could be really hard to dig out the artery from the pancreatic necrosis area. But if it's a venous bleeding, you probably have time to do something to try to tampen out this. I had one case I did Operative procedure with vein reconstruction, and patient had a pocket of fluid that got infected, and they went in, did this drainage, did some aggressive cleanup work, and basically pulled my proline suture from the portal vein because they saw there was some necrotic area. So you can imagine when that happened, there's nothing else you can do because the portal vein started opening up and significant bleeding. Although in the end they were able to control the bleeding, but the patient developed portal vein thrombosis. They eventually, died from it. So my point is, obviously you don't want that to happen. But whenever you do necrosectomy, communication with the surgery team. If my patient needs a necrosectomy, I typically will go down endoscopy suite and watch it with our GI team together. And I would say maybe don't grab this area with your special grasper. But because if that happens, there's not much you can do about it, especially for venous bleeding.
Yeah, our center, we see a lot of this. I'll start by the multidisciplinary approach about timing of interventions. When we started doing endoscopic transgastric necrosectomies, we had this concept of having the HPB surgeon on backup, and so it was always a formal discussion. As our amazing gastroenterologists are, as they've gotten better and better, that has become a little bit less. Now we're always already involved, but we may not be noted like, oh, today we're debriding the patient. As we've gotten to more of these endoscopic, coldocoduodenostomies, gastrojejunectomies, hepatogastrostomies, we have a policy that you have to have the HPB surgeon that signs off on it. And so that person who signs off on it is on deck if there's a problem. Fortunately, it's not very often, but we've all had kind of an instance where we've had a problem, we've had to fix it surgically. Now, from the bleeding perspective, actually 2 of my junior partners are in the room who've had this experience where they have had to go in and control arterial bleeding from a necrosectomy. And so it's horrible. I mean, none of us want to do it. It's a terrible case. You're taking huge prolines through huge spaces, and hopefully you're getting compression. But typically, I do agree that going to arteriogram is best first. Now, if it's a trainee that contacts them, then they say CTA. But if the attending contacts endometriology, then it's arterial.
Yes, exactly.
So that's why the importance of communication with the other team. And so when I get that call, I'm like, well, why are you calling us? Go call, IR needs to go first, and then we'll see what happens. And so, it's complex, but I think it's that level, the attending to attending communication is going to be the critical component of that. I think that's come up a couple times.
My radiologist want a CTA, even when I call them personally. I don't know.
They say the same thing, but I'm like, are you kidding me? I mean, it's like you're really going to waste time.
I mean, if the patient's unstable, then I say
Yeah.
no. But if we can temporize it and
I've told
the
them, why
vitals
don't you
are
come
okay,
over
then
to
I
the
think it's
endoscopy
okay.
suite and see for yourself whether the patient has a CTA.
See, this is the best part of DDW right here. Well, even though the surgeons are outnumbered in this room, we are really grateful for the participation and collaboration between our GI colleagues and surgeons for this panel. Thank you to our speakers and for the audience for participation. Thank you.